So we are live in 5, 4, 3, 2, 1. We are live now.
Right. Thank you very much. And welcome all the dignitaries, speakers, and all the council members who are here. With your permission, Mr. President, I am sharing this screen. And so we are here live for a joint webinar. There is some sound. So this is a joint webinar. Is it visible? No?
No, not yet, sir.
Okay, not yet. Something wrong has gone.
No. What you can do, sir, you share the screen, not the PPT.
I did.
Yeah,
Right.
now you've done better, and then you can go to PPT presentation. Yeah,
yes, sir. Now we can see your screen, sir.
Right. Okay.
Yes, sir.
So, friends, welcome you all. And this is a joint webinar on the topic of osteoporosis, hidden facts. It is organized by the Presidential Theme Subcommittee on Strong Bones, Stronger Nation. And IOA Rheumatology Subcommittee is also a joint partner. Now, with Dr. Atul present here, our president, he has been busy on this bone and joint inaugural day. So now I will like him to inaugurate and address this gathering, virtual gathering.
Thank you so much, Jha sir, and welcome to all on the panel. Well, first of all, congratulations on this 12th Bone and Joint Week celebrations with kickstarts today. And what better way to do it with the joint collaboration of the subcommittees on President's theme, that is osteoporosis and rheumatology. We have the best in the panel, and all the best, eager to listen to you. Thank you, sir.
Right, thank you. For some reasons, Dr. Chaddha, our president-elect, is not there. Dr. Agrawal, he also has not joined. Dr. NAVIN, THAKKAR, the Secretary General, I also don't see him. Maybe he is very busy. And now we request the President of Indian Orthopedic Rheumatology Association, Dr. Shantanu Lahkar, to say his few words, opening remarks.
So good evening, esteemed faculties and participants over here. I, on behalf of Indian Orthopedic Rheumatology Association, extend my heartfelt congratulations to all of you for organizing such a wonderful seminar today. Strong bone, strong nation, and definitely this will go a good way in this subject. And I give my best wishes for this conference. Thank you, sir. Thank you.
Thank you, friends. Well, talking about osteoporosis, we have to remember that by the year 2050, it will be a nightmarish experience. And the hip fractures, which in 1950 was only 1.66 million, will have almost 6 times increase in 2050, reaching 6.26 million. So only the load of hip fractures can be understood apart from major orthopedic fractures that gets in an osteoporosis patient. Well, talking about Indian population, there is high incidence among men also, and 1 out of 8 males are affected, 1 out of 3 males are also affected. Hip fractures, talking about hip fractures, they are almost equal compared to the Western world, and the lower age of peak incidence is also there for the hip fracture. Peak incidence takes place in India at the age of 50 to 60 years, which is 10 to 20 years younger than the Western population. Well, talking about epidemiology, 1 in 5 over the age of 50 years, fragility fracture is there. And in the down bottom also you can see 1 in 5 over the age of 50, another vertebral fracture might take place within a year. Women, 1/3 aged 60 to 70 are there, and 2/3 aged 80 or older, they get it. 30% patients have more than 50 years, 1 or more vertebral fractures are there. And with a vertebral fracture, there is 5-fold increased risk of a new vertebral fracture or 2-fold increased risk of a hip fracture. Well, whenever we are talking about osteoporosis, most of the times fragility fracture is the outcome, and the diagnosis is there only when fragility fracture is there. The reason is in 2/3 of the patients, pain may not be there. They are asymptomatic. There could be a loss of height by up to 2 inches or more than 2 inches, and then it becomes almost diagnosis. Each one of us are aware that the kyphosis in osteoporosis is also known as Doeger's hump. It also allows restrictive lung disease to take place, and the abdomen becomes protuberant. The psychological effect also leads to depression. There is loss of productivity, loss of independence, and there is increased mortality rate. Most importantly, each vertebral fracture decreases forced vital capacity by 9%. Hip fracture leaves behind permanent disability in 50%, whereas 20% have excess mortality. Well, friends, the major risk factors are low bone mass, advancing age, previous fragility fracture, glucocorticoid-induced osteoporosis, which in fact is a combination of suppressed bone formation and enhanced bone resorption. And the propensity to fall is so very much important. Well, the spontaneous or following minimal trauma, these fragility fractures take place. And a fragility fracture, all of us are aware, it is defined as falling from standing height or less. Most characteristic fractures are vertebral fractures. 2/3 are, of course, not clinically diagnosed. Hips, humerus, or distal radius are routinely fractured, but other type of fractures can also take place. The contributory factors are low BMD, like 2-fold increased risk for every 1 standard deviation in T-score. As far as age is concerned, 2-fold increased risk for every decade of age more than 60 years. Previous fragility fracture, the person has 5-fold increased risk of a future fracture. Frequent falls also is a factor, and glucocorticoid is a major contributing factor. There are certain pearls that I will like to enumerate. Older person is more likely to suffer a fracture than a younger person with exactly the same T-score. Now, this is true for glucocorticoid treated patients as well. Both age and glucocorticoid affect bone mass and bone architecture, putting patient at risk for fracture at a higher T-score. History of fragility fracture establishes a diagnosis of osteoporosis regardless of the BMD T-score. This is so very important. Men aged less than 50 years and not post premenopausal women, BMD has to be taken into consideration, not by T-score, but by Z-score. And if the Z-score is -2 or less than this at a lowest skeletal site, this is a patient of osteoporosis. Now, Frack's risk score, 10-year probability of getting a fracture. If it is more than 3% for hip fracture and 20% for major osteoporotic fractures, which in short we say MOP. They are also useful for diagnosis of osteoporosis. Friends, mass and architecture are so very important. If the architecture is properly maintained, it can put in load of mass to a larger extent compared to a structure which does not have a proper architectural pattern. So osteoporosis is a skeletal disorder in which there is compromised bone strength. It predisposes to fragility fracture, and bone strength is determined by both bone mass and bone quality. Friends, I do herewith call upon Dr. Murali Poduval to speak on osteoporosis, definition, relevance to bone mass and architecture. Well, let me introduce Dr. Murali Poduval. He is Associate Editor ISAO, and he has been working with Tata Consultancy Service, and he is a senior consultant and subject matter expert in IoT and DE. Also involved in life sciences and medical device engineering from Mumbai. Dr. Murali Poduval, I stopped sharing the screen and now it is your turn.
Thank you, sir. Thank you very much. So kind of you. I'll start sharing my screen.
All right, please.
So I have been tasked with the idea with
You must be having a slideshow.
yeah, there is a little problem with the slideshow. You just go to slideshow first, and then I will do it so that I am.
No, your screen was visible.
No, the one
Okay,
second.
go ahead.
The problem is that the Zoom toolbar is obstructing my slideshow.
Okay.
Just give me a second, please. The toolbar is obstructing my slideshow.
You can go ahead, even otherwise.
Can minimize
Okay,
the
here we
size.
are.
Oh, yeah.
As you remember, I am working for an engineering concern, so I should be able to show. So.
Right.
Good evening, everybody, and thank you for joining in. I'm talking on definition and relevance to bone mass and architecture on the subject of osteoporosis. Now, if you look at the accepted definition of osteoporosis, it is defined as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. Now, this was proposed by an NIH, National Institute of Health, NIH is National Institute of Health, a consensus panel in the year 2001. Now, I will base my entire talk on just two references. These two references are Osteoporosis, the evolution of a diagnosis by Lloydson and Cummings, and Osteoporosis, the evolution of a scientific term by Shapira and Shapira. These are the only two papers I could find which actually addressed the concept of the definition of osteoporosis. There really isn't any other paper which really discusses this. What are the concerns which are raised in defining osteoporosis? It was defined in French in the 1820s as a definition of a mere pathological state of the bone. But the word did not make its way into the English dictionary till the 20th century. So it was not so much considered important. The very fact that it's a disease or a condition or a disorder was something that was a matter of conjecture. The definition of osteoporosis has consistently reflected the state of knowledge about the condition. Because as it evolved over the years, one came to know that the definition of osteoporosis has taken into consideration various factors about bone metabolism and bone remodeling. So there has been a difficult balance between physiological and clinical criteria over the 170 years of evolution of the definition of osteoporosis. What prime questions we come to see something very arbitrary, that femoral leg BMD of minus 2.5 standard deviations as a cutoff for diagnosis of osteoporosis, and minus 1 to minus 2.5 standard deviations of the normal of the population for osteopenia. There is no evidence to suggest that fracture location or severity is a significant factor in defining the diagnosis, and that fracture risk models do not consider bone strength from diagnosis. When you look at treatment thresholds, because when you make a diagnosis, you have to have treatment. So if you look at treatment thresholds as a trigger for diagnosis, most treatment thresholds are based on socioeconomic conditions. So the NIH definition did not take into consideration bone strength, which is primarily due to bone density and quality. But it did say that there is a decrease in bone mass per unit volume. And there is a deterioration of trabecular microstructure, the loss of trabecular continuity and cortical thinning, which we all know. So what are the approaches to define osteoporosis? A number of approaches are there. Most commonly has been clinical, which we all use. Endocrine regulation of bone metabolism and bone mass, pathology and histology, bone mineral density, fracture characterization, risk model for fracture prediction, and thresholds for pharmacological management. And we'll go through each one of these one by one. But historically speaking, in 1822, Sir Ashton Paton Cooper observed an association between abnormal bones and fractures. It was much later in 1830 or 1840 that Jean Lobstein, he's got a much longer name, which I did not put here, French pathologist and surgeon, he was credited to the first use of the term osteoporosis, probably combining the word osteon with the root in the word osteitis, with porous literally meaning porous bone. So, but it was much later, even another year or two later, that in 1941, Fuller Albright reported vertical fractures in women with ovarian dysfunction. And he found that these were reversed by estrogen treatment. So that's when we started understanding the concept of postmenopausal osteoporosis. And over a period of time, vertebral fractures have become the hallmark of the disease. Again, historically speaking, mid-19th century onwards, a more rigorous definition was attempted away from the literal one, porous bones, the literal definition. Two major causes were mentioned. One is the absolute decrease in bone mass per unit volume, and the second was abnormal draining of minerals, which is calcium cause. Therefore, there came to be three important characteristics with more refined methods of assessment. You need a general term for the disease, you need criteria for isolation and standards to define the term. But surprisingly, it took quite a long time till the mid-20th century for the term disease to be applied to the definition. It was not just bone porosity, but a bone disease or a disorder or condition, despite the fact that the disease, disorder, or condition mean entirely different terms. There was a vagueness and ambiguity of these terms, leading to confusion in defining osteoporosis and osteomalacia. Now, today we have high precision tools, so we are able to contribute a little bit more to the definition of osteoporosis, whereas individual BMD variation would have been ideal in refining diagnostic criteria is practically difficult. So we have to depend on a population mean. Now, what about clinical investigation? What commonly we see generalized body pains and vague aches and vague symptoms which come across with osteoporosis, which may not contribute to the diagnosis of osteoporosis. More specifically, we have fragility fracture, thoracic kyphosis, including loss of weight and back pain, which can be distinguished by occiput to wall distance or the rib to pelvic distance, hip fracture, signs and symptoms of secondary osteoporosis. Riggs and Melton in the year 1983 divided osteoporosis more or less generally into type 1, which was postmenopausal, and the second was senile osteoporosis. But this was not very easy to justify in clinical studies. Then came the age of BMD. Cameron and Sorensen in 1863 came up with single photon densitometry. This advanced slowly till the 80s, when DEXA became more common. And in Geneva, with the Geneva Convention in 1992, a BMD of less than 2.5 standard deviations below the mean of a standard healthy population matched for gender and ethnic group are considered significant. And this was adopted in 1994 into the WHO definition, which kind of mirrored the same thing. And so bone mineral density became the gold standard. So osteopenia, defined as more than 1 and less than 2.5 negative below the mean for a young and healthy population. BMD below 2.5 standard deviations of the standard mean population, a young and healthy population, could be because considered as severe osteoporosis. And based on spine and hip BMD, the US National Osteoporotic Foundation found that it could be more or less correlated to the actual incidence of osteoporosis. But still, people felt that BMD at other sites, such as radius, should also be considered. The problems with bone mineral density, or BMD as we like to call it, is that there are confounding effects of the results because of surrounding soft tissue, aortic calcification, vertebral compression fractures. It also is not a very clear indication of bone microstructure or quality. It is believed to influence fracture risk. It's also a two-dimensional structure. True volumetric BMD on bone size or separate trabecular from cortical bone is not a clear advantage of doing DEXA. A large bone generally yields a higher BMD than a small bone, but the volumetric BMD would still be the same. Could we use the histopathology for defining osteoporosis? That is another question, because how do you use histopathology to get down to a diagnosis? You need to do a biopsy. That would be difficult, because the 1994 WHO definition is still BMD based and does not take into account bone microarchitecture or quality. So then we have to depend upon CTSS bone structure or finite element analysis to determine bone strength, which will give you an idea as to what is the actual strength of bone, what is the actual reduction of bone per unit volume. Now, there is a technique which has come into play recently, which is not much validated, which needs much further study. It is the reference point indentation. There is a device known as the osteoprobe, which does an invasive measurement of bone mineral strength by actually measuring, without causing much discomfort, the resistance of the tibia to microfractures. But we are still not in a position to delineate what values devised by this reference point indentation or osteoprobe are significant to define osteoporosis or to say there is no osteoporosis. That still remains a question. Now, when it comes to fractures, we always talk of osteoporotic fractures, but are there osteoporotic fractures? Are there really osteoporotic fractures? Can you say that by the occurrence of certain fractures, osteoporosis exists, or the diagnosis is confirmed? It is surprising to see that there is very little evidence for diagnostic confirmation of this fact. In fact, it has been found that patella, clavicle, pelvis, and lower leg fractures are closely correlated to femoral neck BMD rather than hip and spine fractures. But vertebral fractures still remain unique. Vertebral fractures you can still consider as part of in conjunction with BMD to be diagnostic of orthopedics. Second fact is about low energy fractures or traumatic fractures with significant trauma. Again, this is not justified or validated by literature. That low energy fracture and diagnostic of orthopedics or traumatic fracture diagnostic of orthopedics of osteoporosis. Now, the last point is using fracture risk and treatment thresholds to define it. What we all know about is the FRAX score. But what we don't think about is that there are factors other than osteoporosis that pose a fall risk. There could be smoking, there could be neurological problems, there could be age itself, there could be vertigo, there could be anything. Osteoporosis cannot be defined just as a high fracture risk. And it is possible that an individual with a high fracture risk is living in an area where there's a low risk of fracture, low risk of fall. And a person with a low fracture risk is living in an area with a high risk of fall. Therefore, to use a FRAX score itself to define osteoporosis is not reasonable. As with BMD, the relationship of risk fractures, risk scores and fractures is continuous with no specific cutoff. We don't have a cutoff. Beyond this is osteoporosis. Below this is not osteoporosis. Below this is osteopenia. We don't have a cutoff. These scores do not permit. They only allow you to determine if fracture is going to occur or not, or what is the risk of fracture occurring. So you cannot use them as diagnostic criteria. Similarly, the problem with treatment thresholds. Because if there's a diagnosis, there has to be a threshold, there has to be a treatment. Can you determine as starting of treatment as a diagnostic threshold for osteoporosis? There is no literature to support that. So we are back to the NIH consensus panel definition of 2001, which remains the most comprehensive diagnosis, as osteoporosis defined as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. And this can be supported by the BMD findings. With this, I end my talk and I hand it back to Dr. Jha.
Thank you, Dr. Murali. Okay, right. So I will now share the screen. You have deliberated very sincerely all the points hovering around the subject of osteoporosis. You have gone into the background of definition of so many years, and you have also discussed about how it is going to affect the management. Well, as orthopedic surgeons, we all of us are aware that when we instrument, I'm again not visible.
I think I've stopped sharing, sir. You should be able to share.
Yes, something is wrong.
No,
Again.
sir. I think you have to stop. So
Yes,
you share the screen, sir. That will work out.
I think so. Okay. Now I will share. That will work. Yes. Right. So now the screen is visible. Right. Right. So we had the presentation from Dr. Murali, and that was a very good presentation. He has raised questions and he has also answered that yes, there are certain indexes which can be put into question, but they are thought to be very practical as well. So thank you, Murali, for your presentation. Now I move on to the next one. Now this is the amount of elemental calcium in the various calcium presentations. So what is the importance of calcium? Apart from its role in bone formation and maintenance, and also in the health of the teeth, it is very important in blood clotting, then vascular and muscle contraction, nervous system functioning, cellular transportation, cellular signal transduction, even hormonal function and enzymatic activation. Well, main causes of calcium deficiency, all of us are aware that vitamin D has been highlighted more than anything else, but there are situations like magnesium deficiency or lactose intolerance or milk allergy, postmenopausal, all of us are aware, a poor diet and a impaired parathyroid hormone function, they are responsible. So bioavailability of calcium in various calcium salts, we keep on prescribing various calcium salts, maybe even without knowing the limitations. Dr. SS Amarnath, now it is your turn. Thank you. And I stop here.
Thank you, Dr. Jha. Thank you. Good evening, friends. And I'm going to share the screen now. And I'm visible and the screen is clear.
Yes.
Wonderful. Thank you. Thank you, Dr. Jha. Friends, it's a pleasure to open 2023 Bone and Joint Week and Day. What better way, as the President Atul Srivastava said, that we are having a webinar on osteoporosis, and this is the hospital where I work, and two major organizations that I'm associated with apart from IOA, and I'm very thankful for that. And I appreciate IOA giving us the opportunity and the Rheumatology Subcommittee to have proposed this on kickstarting the 2023 Bone and Joint Week. And this weekend on 6th, we're having a cyclothon in Bengaluru with orthopedic surgeons. It's going to be fun. Anyway, we'll keep you updated on that. And coming to today's topic, we have learned a lot of things. Pandemic literally in our life have taught us so many things. My grandmother used to talk about pandemic, what she went through. And in our lifetime, for me, this is the first one, and then a lot of things we have learned. And then one important thing that is, it's a very, very delicate world that each one of us are living. And in this delicate world, it is all the more reason and all the more our responsibility for us to make this, not a delicate bone. And delicate bone has to be addressed. For the presidential theme of this year, strong bones and stronger nation. So definitely, no doubt about it. This is the way forward, when we have to get on with this and take it forward. And what better way? Now, yes, I think in our life, we have learned a lot of things. The biggest challenge for us is the change. It is easy to learn, but extremely difficult for us to unlearn what we have learned and to accept what we want to relearn. That's the biggest issue we talk about. So this is where I come from, and then we take it forward for today's topic of calcium bioavailability. Well, I think Dr. Jha shared a few of his screen there, and then calcium is a very, very important mineral. Nutritionally, it's extremely important for us. This is just a chemical structure to just get an idea of a pharmacological base. I don't need to take you for each and every line there. It's for you and I to sort of focus on and get on with it. Because human body has a huge amount of calcium. We as Homo sapiens, women and men, both of us have a huge, nearly 1.5 kilos, 1.5 kilos of calcium. A large quantity. When once the skeleton is burnt out, we can get the bone ash where the calcium is so much. So naturally, we have a storehouse of calcium. Now, there are certain things that we have done, certain things we need to understand. I may confuse you with certain terms, and you might have already been confused with the pharmacological learning what you and I have done, and the pharma industry coming into picture and promoting a few things, which also has some amount of challenges of how you and I take it forward. So this is where we have a lot of calcium sources. I'm just naming a few here. So literally, I think all of us know, and we use a few which are very, very prominent, and we know that is working. And we all practice evidence-based medicine. Hence, we need to look at that as a biggest challenge. And when once that is done, obviously, you and I prescribe. Where do we go from here with all the salts? Are we going to use tricalcium phosphate, or is there confusion on the carbonate, or is citrate malate a better salt? Never know. And as a postgraduate, as an undergraduate, for hypocalcemic tetany, we knew only that calcium injection what was given to in the past, and that was it. And they thought, oh, calcium is taken care of now, though they didn't have to worry about it. We have gone long way from now. We have come a long way, you know. This is where we stand. Give you an understanding. Now, the chart is very busy. I couldn't alter it. Now, let us talk about calcium carbonate. It's one of the highest ones. 40% it is elemental calcium, and the bioavailability is pretty high there. I'll come to the point of bioavailability as well, and I'll talk to you more about it. But when I compare to the last one on the list, which is tricalcium phosphate, it has 38. But are we using it? No, because the availability of that in our system is a little challenging, moderate to low. So we don't have that salt in a big way prescribing that. So what is the next available? The nearest one that we all have accepted is citric malate. So that is about 21% of it's available. And a lot of challenges are there with our system. One, how much do we take? Two, is it the actual elemental calcium that is needed? Or is it the elemental what is needed? Is it absorbed? Because all of us in our journey, in our life, end up with some sort of an IBS, irritable bowel syndrome, and a lot of other dietary deficiencies because of our food fatty habits that we all pick up to please the tongue for the taste rather than the nutrition value of the food. And to tell you frankly, I think all of us here know and then vouch for it. As children, we have eaten beautiful, good, nutritious food, which has given a good, healthy lifestyle for our, forefathers, and the health in the 21st century has improved upon, and we are living longer. All the more reason that we need to have clarity on this particular subject. So that is where we stand. What is the next one, which is has a bigger elemental calcium? Calcium chloride. Are we going to use that salt? Yes, we have been using it in an IV format for a different reason, but not use it in terms of having it in a big way. But yes, in our diet, we have a lot of things. I'm just comparing a few here. The chart is even bigger than this. I'll not bore you, but definitely it's extremely important point that I need to make here so that we understand where we go from here. The most common salt that we all use is carbonate and citrate malate. Are the two very important molecules that we have in our system of practice. And what's happening? What is confusing here? I think every sentence or every letter or every line when we act upon or put upon is confusing and contradictory to a many extent. Why? Okay, we have a food, we have a diet, we have a supplement which has a beautiful calcium content in it. But is it enough? Are you looking at the content? And there is another challenge now. RDA, recommended daily allowance. Now, we talk about and we concentrate only on the tablets or the supplementation, what we take in the form of liquid or a gel or whatever. We forget the dietary component there. Next comes in, okay, I am taking, patient comes and tells us, I'm sure all of us have gone through in our practice, I'm taking 1,500, I'm taking mega calcium 2,000. Well, when you ask them, are you really taking? They say yes. But when you go into the depth of the challenges, you see the small print, the elemental calcium equivalent to 200 or even 250 milligrams of calcium. It's very misleading, even for the layman and for us as practicing doctors. Second comes the availability as well. Are we talking the elemental calcium as bioavailability, or is it the one that is going to be absorbed? There's an issue there. That needs to be understood. So that's where the whole challenge comes into picture. And WHO has given a clarity on what supplementation should be given to all the Caucasians and all the Homo sapiens. But there is a big challenge there. because people say, oh, Southeast Asians have a different kind of a body set, so we can't accept it. Africans have a different kind of a body system, and Caucasians are different. So that requirement goes up and down for both men and women. Then comes our system in India, which is even more challenging. Whatever WHO has given, FSSA has recommendations, which is half the amount of what WHO has given. We have been fighting with the government to increase that, but we are literally, probably, I think, banging our heads against the wall. Hopefully that will change, and it should for the better. And the government has accepted in fortifying certain food, and calcium and vitamin D and B complex and iron are a part of the fortification. But that's a very transitory thing which is happening, but it'll definitely be, big way coming in. So these are the things that we need to understand here. Elemental calcium is extremely important for us. When you and I prescribe, we talk about elemental calcium. That is where we need to understand. And we have to address each and every patient's requirement and the clinical challenges that they have, the baggages that they have. Could be renal issues, could be cardiac, there could be contraindications of calcium supplementation. We may need to use the different salt. They may be on calcium channel blockers, a lot of things. I think Dr. Jha mentioned about a lot of activities, what the calcium does. I wouldn't want to touch upon each and every point there, but we have briefly understood that. And let us understand here. Now, this is another big challenge. Should I really do calcium assessment serum? Mostly normal. So why do you recommend calcium? A lot of patients ask you and me, and I'm sure each one of us have gone through in our practice talking to them and guiding them. Now, body is a beautiful structure. For all the details what Dr. Jha has mentioned on the functions of the calcium, from head to toe, from the nerve conduction to every heartbeat, and for every pulsation in the bone marrow, calcium is required. Hence, body mechanism is so nice, it maintains the serum calcium extremely high level, or at least in the optimum level. Now comes the challenge. One example, simplifying this to understand everyone who is listening. And if I were to draw the money from the bank, which I have deposited and very much happy with all the interest, I keep drawing it, withdrawing it. But if I do not deposit the money, my bank account goes into zero and minus. That's exactly what is happening in our system. You and I are not focusing on depositing, but we are withdrawing it. Body takes it whether you want it or whether you don't want it. So that's where the whole challenge comes into. By the time in women, it's going to be early due to menopausal age, and in men, it's going to be a little later, where we call andropausal, maybe 60 to 70 years plus. Calcium level and the bone mineral density gets to the maximum by boy and a girl hits 20, 25 years of their life. So that is where the whole challenge comes from. You and I need to address the point there rather than treating them at the challenge when they come with a fracture. So that's where the whole challenge comes into. Now is the issue. Calcium, how much do I prescribe? How much do I take? Now, this is from the prescription point of view, we're talking maybe 1,000 to 1,200 milligrams per day. Now, this is the requirement. Now, am I looking at only tablets, or am I also be looking at my diet? That's extremely important. You and I need to address that. Many of them are lactose intolerant. You and I may have to give them a little larger dose. 2, calcium is a very big, mineral. Comes in a big tablet, not easy to swallow, especially in geriatric patients. And 2, with the IBS and a lot of other challenges, calcium needs to be given frequently. It's like, okay, I've had my first meal of the day. Can I stop eating in the afternoon, evening, and night? Can I go to the next meal tomorrow morning? You could, I'm supposed. Yeah, why not? But is it happening? No. You and I are filling the stomach, but are we putting the nutrition there? Very less, very minimum. Hence, you and I need to put dividing the dose of calcium during a diet. Many times we can still give it before food or after because of the challenges of acidity that can create. So better with the food we talk about. Second challenge, many of the baggages patients come with, they are already on H2 receptors and proton pump inhibitors. Are they absorbing it? Even though the bioavailability is there, is it the right quantity that they're taking? Is it the right quantity that the body is absorbing? Not much. So all these things need to be addressed. We just blindly prescribe because we are too busy with our practice, giving less time to our patients in the nutrition. If you and I don't have the time, I think we should put them on to some nutritionist in our own centers and give them that little extra, what shall I say, counseling, which makes a big difference in their life. So extremely important. So now comes the biggest issue. We address calcium. People talk about thyroid. I've done all the blood tests done. Thyroid is normal. Why should we do other tests? When we know vitamin D osteomalacia is there, vitamin D deficiency is there, and it's been regulated by parathormone, we forget the parathormone levels. Do I need to do it every day for every patient? No, not required. But we need to address that. But are we doing it? Is the biggest question that you and I need to ask for ourselves. So we need to address hypercalcemia. Without the presence of vitamin D and the other vitamins, calcium absorption is going to be very minimal. You need vitamin C, you need B complex for all the chemical reactions and actions that pick up in our body to metabolize and assimilate and digest and give us the optimum level of calcium in our body, not only in the serum, but has to be deposited in the depository regions, mainly skeleton, what we have. That's extremely important. I think that needs to be addressed. In 5 or 10, 15 minutes of talk, it's not easy. And I'm touching upon a few points. That's the reason. That's all I did. And that's all I can do. And we can take it forward from there. The biggest myth, every patient, even the doctors have this. Oh, don't take too much calcium. You're going to have renal stones. Do you really agree with that? We have nephrologists in the panel. We have orthopedic surgeons in the panel. We have rheumatologists. We have immunologists and hematologists in the panel. And we all agree it is a myth. In fact, no, not osteomalacia. In fact, hypercalcemia causes more of renal stones. We all know that. But renal stones are more of oxalate rather than calcium. So this is just to give a highlight on the myth. With this, I think I'm going to end my talk. And this is our not just prescribing, it is our responsibility for every prescription of ours with medicine to make a nutrition prescription and calcium. Being practicing orthopedic surgeons, we include that and let us make stronger bones for the stronger nations. Thank you. I'll stop sharing.
Right. So thank you, Dr. Amarnath, for a very lucid presentation on various calcium preparations and all other related topics. Well, now I share my screen once again. So you have very rightly shown the presence of elemental calcium in various preparations, and you have already highlighted that calcium carbonate is the highest one. Now, the calcium salts, their pH, their solubility, also as highlighted by Dr. Amarnath, has to be known. So there are various factors, the water solubility of various calcium preparations, calcium absorption from different calcium salts, bioavailability of calcium from various calcium solution at different concentration, natural sources such as coral calcium, dolomite, and oyster cell. Potential adverse effects of calcium supplementation also has to be looked into. And not only that, interaction of various drugs with calcium also it becomes very important. And calcium supplement interactions with food also becomes. So it is a vast subject. Dr. Amarnath, thank you very much for doing justice to the topic. Well, what is the kind of workup when we get a patient of osteoporosis, or for that matter, any other patient? So there has to be a complete history, and I always keep on repeating, talk and talk endlessly to the patient till the patient gives you a diagnosis. And this is true for osteoporosis as well. Physical examination becomes very important, and it has to be followed by cost-effective lab tests to identify the underlying disorder. But the moot question is, do we really require advanced pathological investigation? And who can best answer this? Investigation and monitoring, Dr. Renuka P. will do it. Dr. Renuka, I stop sharing and this is your turn. Well, before that, I must say, Dr. Renuka is a consultant at Chinmoy Rheumatology Center, and she is here with us. Dr. Renuka, please.
First and foremost, thank you, Dr. Jha, Amarnath, and IOR for having given me this opportunity to speak on this topic. And I hope that I do some justice to your expectations. When you talk about osteoporosis, so osteoporosis basically happens when there is an imbalance in the equilibrium of bone formation and bone resorption. The bone is a dynamic organ which undergoes constant bone formation and bone resorption. Bone formation which occurs by the osteoblast and resorption which happens by the osteoclasts, which are the cells which are present. And if there has been a disturbance in this equilibrium, then and with increase in the bone resorption and increased osteoclastic activity, then osteoporosis develops. Osteoporosis, when we say, it could be either primary or secondary. It could be, and when you say primary osteoporosis is what we'll focus on, that primary osteoporosis could be generalized or localized. And the most common forms for the causes are the senile osteoporosis or osteoporosis happening in postmenopausal women. When you talk in terms of investigations, I mean, we heard so much always that the clinical examination, patient symptoms, and radiological investigations are the one which are the major investigations which are done primarily for diagnosing an osteoporosis, particularly the DEXA scan. And the definition itself goes by the BMD scan values. So then why do we need to do the laboratory investigation? Because when you talk in terms of a BMD or a DEXA scan, what happens here is it is a status which has already happened to the bone. So it tells you what has already happened in the past. Whereas the bone, the lab investigations like bone turnover markers, they are dynamic and they actually tell you what is happening with the bone, whether there is increased formation, increased reception, whether there is decreased formation, rather, I would say. And that is what happens. So whenever we do an investigation, usually, but however, for osteoporosis, the investigations are not done for diagnosis of osteoporosis. It is more for ruling out the differentiating the primary from the secondary causes. The most commonly done basic investigations are a complete blood count with ESR or CRP, which tells you whether the patient has anemia, whether the patient has an inflammatory condition, which will help us in identifying the cause. Because the secondary causes could be numerous, right? It could be hormonal disturbances like hyperparathyroidism, hyperthyroidism. It could be because of inflammatory disorders like rheumatoid arthritis. It could be because of GI disorders where there's malabsorption. So secondary causes could be multiple, and we need to differentiate and separate out and do tests to rule out the secondary causes of osteoporosis. The next is The next is, of course, the serum calcium, which just now Dr. Amarnath spoke elaborately on. Serum calcium, and sometimes a 24-hour urinary calcium may be required, as well as serum phosphate, because bone, we know, is an organ which is composed mainly of collagen. It has mineral proteins, as well as like osteocalcin, and it has calcium in the form of calcium hydroxyapatite and bound phosphate, which is also present bound to the calcium, and also with cells like osteoblasts and osteoclasts and osteocytes. So this calcium becomes very important because it plays an important role in the metabolism of the bone. So it has to be tested, and serum phosphate also. The serum calcium metabolism is affected by PTH and vitamin D, as Dr. Amarnath has already said. Whenever there is a decreased calcium, the parathormone hormone is released by the parathyroid gland. It gets stimulated, causes absorption, increased calcium absorption on the large intestine, mobilization
There
of the
is some
calcium from the bone.
with your, right.
Is there a disturbance? 1 second, just hold on. Is it fine now?
Right.
Yeah. So basically, whenever there is a low calcium level, the parathormone causes mobilization of the calcium from the bone. It causes increased renal tubular absorption, as well as causes increased absorption from the intestines, and thus causes a feedback. It causes an increase in the calcium levels. And vitamin D also plays a role, which causes increased absorption of the calcium and phosphates from the intestine. So that's why it becomes important to check whether the calcium levels is normal or high, and whether there are other disorders. Suppose usually in primary osteoporosis, the calcium levels will always be normal. If the calcium level is elevated, it could be because of hyperparathyroidism. It's something which we'll need to look into, or it could be because of a renal condition. Similarly, if your calcium is normal, and we also do liver function tests, most of all the alkaline phosphatase. Again, here the alkaline phosphatase comes both from the bone and the liver. So there are different isoforms which are available, and it is not very specific, but it helps out in differentiating, like increased ALP with a normal calcium, normal phosphate could very well be there present in Paget's disease. So it helps out in differentiating the secondary causes of osteoporosis. So these will be the investigations to rule out secondary causes of osteoporosis. But now we are having a lot of new markers which are available, which are called as bone turnover markers. These are excellent indicators because, as I said, they represent actual activity, and it is dynamic as it is happening in the bone. So it represents the functioning of the bone remodeling, which is happening at a particular point. It is useful for monitoring, It is useful for monitoring individual osteoporotic patients. It holds also a promise in fracture risk prediction and monitoring. So here, if you look at it, when you look at the bone remodeling, so the bone formation, this is in quiescence, this is in a perfect balance. When there is an imbalance, as I mentioned, you can have increased resorption causing osteoporosis. And the osteoblasts are the bone forming or the anabolic cells, and the osteoclasts are these are the osteoblasts, these are the bone forming cells, and these are the osteoclasts which are present on the cell surface, which are the giant cells. The osteoblasts release enzymes as well as proteins like bole alkaline phosphatase, osteocalcin, P1NP, which is basically a pro-collagen, and pro-collagen, which has an N-terminal, is called as the amino terminal, is the P1NP, and these are propeptides, the P1CP, which is the carboxy terminal. So these are collagen, because bone 90% is formed of collagen, and pro-collagen is the one which is the precursor for it, and these extra peptides are spliced by the proteases and then incorporated into the collagen or the matrix of the bone. So these are the ones which are the bone formation markers. That is the bone alkaline phosphatase, osteocalcin, P1NP, and P1CP. Now, when it comes to this, the rank ligand, how is this? And the bone osteoclastic are the enzymes like cathepsin and TRAP, as well as collagen degradation products like hydroxyproline, hydroxylysine, calcium, pyridine, D-pyridine, as well as the telepeptides of the collagen, which are spliced again at the periphery, which could be the N-terminal or the C-terminal, called as NTX1 and CTX1. These bone formation and resorption is regulated by some of the regulators, and this is most common of which is the rank ligand pathway or by the WNT pathway. The rank ligand is secreted by the osteoblasts, whereas the rank receptor is actually present in the osteoclast, and the balance of this, the rank ligand works on the osteoclast, activating it, causing the degradation of the bone. But there is another protein which is secreted by the osteoblast, that is the osteoprogerin, which is a decoy receptor and inhibits the rank ligand activity. So that is why, if you see, these regulators like rank ligand and osteoprogerin are also secreted by the osteoblasts, as well as the osteocytes also in addition release sclerostin and the decoy protein 1, which is the DKK. So if you look at this entire process of formation as well as resorption and the regulators, there are markers which can now be analyzed in the serum or the urine, and which we are calling as the bone turnover markers. So the bone turnover markers are the bone formation markers which are secreted by the osteoblast, that is the serum bone specific alkaline phosphatase, serum osteocalcin, and the serum type 1 procollagen, which could be either at the C-terminal or N-terminal, called as C1NP or P1NP. These are the bone formation markers. And the bone resorption markers can be analyzed both in the urine as well as in the serum. The urinary ones are the urinary hydroxyproline, urinary total pyridinoline, as well as deoxypyridinoline, and the cross labs or the collagen cross-linked telepeptides of the collagen 1, which is the NTX1 and CTX1. Now, similarly, the same markers, particularly the CTX1, NTX1, can be measured in the serum, as well as the enzymes such as the tartrate-resistant acid alkaline phosphatase TRAP5 and bone sialoprotein. These are the bone resorption markers in serum. And then you have the regulator markers, which I have already discussed, that is the rank ligand, osteoprogerin, Dickoff-related protein, and sclerostin. So that is how you classify the bone turnover markers. I know that these names are so many and there are so many markers, but then the question comes, why are we not using them? What are the problems with it? Basically is because of the wide biological variability which happens in, and as well as the challenges in performance of these assays, which has caused the limited use of these bone turnover markers. The osteocalcin and bone-specific alkaline phosphatase are some of the few bone formation markers. The osteocalcin is a very high specific marker for high bone turnover and has a low within person variation. But however, it's limited by its use because of the rapid degradation in the serum, diurnal variations, renal functions affected, as well as by the variable vitamin K levels will change the values of osteocalcin. So if it is not available in the serum by the time you test it. So that is the major challenge which you find with osteocalcium. The alkaline phosphatase, which we discussed earlier, was present in the liver, and you have a specific bone-specific alkaline phosphatase, which plays a crucial role in osteoid formation and primary mineralization. This enzyme is active at alkaline pH and is antigenically very distant from the liver form, as well as the placental alkaline phosphatase. The good part of this particular marker is that it is unaffected by the renal function and serves as a marker of bone turnover or bone formation in the management of osteoporosis patients with chronic renal failure. But more than that, there is one bone formation marker which has got on the lot of attention because of its advantages, and which is the type 1 procollagen N-terminal, or also called as the propeptide of the procollagen, which has the N-terminal and the C-terminal, which I have already said when it is secreted by the osteoblasts, and these are markers of the bone collagen deposition. These peptides are released into the plasma and can be measured easily by automated analyzers. And it has been recommended as the reference bone formation marker by the International Osteoporosis Foundation, as well as the IFCC and Lab Medicine. Why is it preferred is because of its low inter-individual variability, smaller circadian variations, and it remains relatively stable in serum at room temperature. However, of P1NP and P1CP, the P1P is a preferred over the P1CP because the variations are comparatively low with P1NP as compared to P1CP, and it is not affected by hormones such as growth hormone and thyroid hormone. And what we measure when we talk of P1NP are which measures both the intact trimeric form as well as the monomeric form. So it is a total P1P assay which we use usually, which is available in different equipments like Roche Alexis instruments. It has been reported that it correlates very well. It has been found in studies that the values actually increase when the patients are given treatment with parathyroid hormones or alendronate therapy. And it is a very sensitive marker when you are monitoring the patients with patients on treatment. There are other resorption markers. So when we talk of bone formation marker, I will just reiterate over here, P1NP is the marker of choice because we have so many markers and it becomes sometimes very difficult to remember and understand, in a crowded, which one to choose. So the other markers are urinary hydroxyproline as well as urinary pyridinoline and dipyridinoline, which are the ones which are present, which can be detected in the urine. Urinary hydroxyproline is newly synthesized collagen. Actually, it's derived from the degradation of the newly synthesized collagen and found in other tissues also, as well as in dietary sources. And it's a very non-specific marker of bone turnover due to its low sensitivity and specificity. When it comes to PYD and EPT, that is, they can be tested very easily with ELISAs, but then still it is very cumbersome test requiring about 24-hour urine collection, or otherwise you can do it on a random sample, but with creatinine correction. So these being a little cumbersome, PYD and urea hydroxide, these have now not been used. Then when it comes to serum, you do also the bone sialoprotein, which plays a role in the calcification of the tissues and as well as the mineralization of the new deposited bone. And they're recommended for detecting only, but the problem over here is not the entire sialoprotein is being assessed. And when we do the immunoassay, we were able to detect only a fraction of the bioavailable BSP in the serum. Hence, its use is also very limited. Coming to the other marker, which is the tartrate-resistant alkaline phosphatase 5B, which is increased in patients with osteoporosis with a very high bone turnover, and it reflects increase in the number of osteoclasts. It is elevated in about 80% of patients, and it is not excreted in the urine. That being the thing, it does not start accumulating because of a renal dysfunction, and it is useful in monitoring patients who have a renal dysfunction with osteoporosis. We already said that P1NP was a marker for bone formation, which was the preferred marker. The other marker for bone resorption, which is a preferred marker, is the collagen type 1 cross-linked And this could be again at the telopeptide, could be at the amino terminal, or as well as the carboxy terminal, called as the NTX1 and CTX1, which are the markers of osteoclast activity. These are also referred as cross labs or beta cross labs, what we call them, because usually the one which we assess is the beta isomerized form, because they are actually available in two isomerized form, alpha and beta. And as the bone, as the ages, the beta CTX is the one which is the one aspartic acid gets converted and which is usually formed. Hence, it is recommended for anti-resorptive therapy in patients of osteoporosis. NTX is, which can be measured both in the serum and the urine again. But however, it gets affected by postprandial variability is much more compared to CTX. But when it comes to resorption markers, CTX1 has been recommended as a reference bone marker by IOF, IFCC, and lab medicine. And it is commonly used, considered to measure the degradation of the relatively older bone. So that is why it is a marker of choice. When so many markers are available, I mean, maybe you should all tell me that how are we not using it so much? And the usage is so limited. Of course, cost is also high. Why are these so many challenges there? Is also because there are other problems which happen because of the various factors which affect the measurement of this bone turnover markers, formation markers, be it or resorption markers. So there is a wide circadian variation which is noted with this. Concentration of BTM markers are known to be higher at night and lower in afternoon, particularly markers like resorption markers like CTX. So that is why it is ideal to take a fasting sample in the morning between 7 to 10 a.m. So is ideal for testing the BTMs. It can be overcome. So these are all modifiable factors which I'm speaking on. Now, food is intake and effect. So that is why, as I said, fasting is a preferred sample. Seasonal variations can be there. It is showing higher levels in winter and about 20 to 30% increase if you take in the same individual compared to in summer. But that does, so if possible, you look at the seasonal variations you might, but at least you can keep that in mind when we are interpreting the assets. And overall about there's a 10 to 20% variation with the menstrual cycle. So usually you take it in a luteal phase and the 7th day. So like that, you try to circumvent this in women when you're testing. But when you're doing it in postmenopausal women, this is not a challenge that we face. Medications, oral glucocorticoids leads to dose-dependent elevation in bone formation markers. Aromatase inhibitors cause an increase in the bone turnover markers. So we have to look into the history when we are interpreting these tests and avoid intense exercise before you do these markers because exercise can increase the BTMs. So that being the thing, it is ideal to take a fasting sample between 7 to 10 a.m., preferably in the same season. If not possible, at least take that into consideration, as well as to take the drug history so that it is not affected and patient should not have done too much of exercise before he gives a blood sample. If we are doing any of the urinary tests like NTX1, in that case, we should take ideally a 24-hour urinary sample, or if it's a random sample, we should also collect for creatinine. The other factors can also be there, like age. In women, as we know, where menopause and estrogen therapy influence menopause, there is an increase in the BTM levels. It has been noted there's not much of a variation with ethnicity, but if a patient has had a fracture already, then there will be an increased BTM level. Chronic renal failure will have high BTM levels. Hyperparathyroidism, as I said, one of the secondary causes, very common ones. Immobility itself can cause an increase in the resorption markers and decrease in the formation markers. So there are other factors when we are taking a history, all these need to be looked into. But most of all, if you take an idea, besides these problems, there could also be problems of which equipment you are doing, how we are doing the testing, whether it's ELISA, whether it's a sensitive marker, what is the shelf life of the sample, in the half-life of the marker in the serum. So that is why currently there are two markers which are the markers of choice. One is for bone formation marker, which is P1 and P, and for bone resorption marker, which is a CTX, beta cross labs. However, we have to keep in mind that if there is a patient who is having chronic renal failure, then you might have to choose other markers like TRAP5 for resorption, and P1NP still does not get much affected. We can still use them. Now, why is it that? So that is why it is mainly useful, but as I said, not just useful in diagnosis, but more for patients. In an individual patient, it is helpful in monitoring patients on therapy for osteoporosis. It shows a rapid response to the treatment. It is useful for monitoring the treatment outcomes, and treatment with anti-resorptives cause a rapid reduction of markers of bone resorption, and with anabolic agents, you see an increase, a rapid elevation in the bone formation markers. When it comes to the anti-resorptive therapy like bisphosphonate, at that time we see it acts by inhibiting the osteoclast, increasing the bone BMD, and of course lowering the risk of fractures. So it is recommended that we should do, when the patient is on bisphosphonate, you will realize that there is a rapid reduction in the resorption markers. So you do a testing at the beginning before you initiate the therapy. You take a baseline values, monitor it after 3 months, and see if there is a change in the bone turnover markers, particularly the resorption markers. So whether there is a decrease in the CTX value, and how do you say it is decrease? It should not be a minimal decrease. There should be a defined, what we call as a least significant change should have happened. So what is that least significant change? Is that the change should be significant, clinically significant, and large enough so as to differentiate that it is actual response to therapy. So which is considered as 50% of the resorption markers, 50% of the value will come down when you are doing the BTM levels on the blood serum samples. Similarly, drugs like denosumab, which is a monoclonal antibody that targets the rank ligand, which is actually a regulator, and it inhibits the bone resorption. So here again, we will see that there is a rapid decrease of the bone resorption marker CTX1 within a few days. But however, that there could also be a P1NP and the alkaline phosphatase, which are formation markers, can also reduce with anti-resorptive therapy. When you're treating the patients with anabolic agents like parathormone, that is the teriparatide, as well as then at that time, there is a dose-dependent and rapid increase in the bone formation markers such as the P1NP, P1CP, and the response reaches peak levels after 3 months, P1NP being most responsive marker, and a small rise might happen in a bone resorption marker also. But the increase in P1NP is so high that even that little bit of resorption marker does not affect. There is another drug which is there, not available probably over here, is the romosozumab, which binds to sclerostin, which is a regulator protein, and osteocyte-derived, which is an inhibitor of the osteoblastic activity. And here again, we'll see that P1P level begins to increase within 1 week, reaches a peak at 1 month, and then slowly returns to treatment within 6 months. So the resorption markers decrease and remain below the baseline value even at 1 year. So if you look at these graphs, if the change in the BTM happens within 3 to 6 months, whereas the changes in the BMD are seen much later and take longer time, probably about 2 years. So it gives a more clear and a dynamic monitoring of these patients on therapy. This helps in enhancing the patient compliance to therapy. When you monitor the patients and share this data with the patient, it has shown to improve the compliance. You can make the patient to see, this was your value earlier of the resorption markers. It has come down with the bisphosphonate therapy or denosumab which you give, and you show the patient this is the value which has changed. Then the patient feels, yes, things are changing. So how we, in diabetes, we monitor with the sugar levels. It helps to the patient to understand, and compliance is better. So we have already discussed, these are the 2 preferred markers are P1NP and CTX. And even in postmenopausal men, if you show that compared to the normal values, their values are much higher, it helps them in understanding the problem and in responding and taking the medications for it. Do these markers have a role in predicting bone loss? See, there is some data which says that they do predict rate of bone loss in population, and higher the levels of BTMs associated with elevated risk of fractures, which we know. And the bone resorption markers and the bone specific alkaline phosphatase are significantly known to have associated with all types of fractures other than any other bone turnover markers. So they're like CTX1 and bone specific alkaline phosphatase. However, what has been noted is that the changes which happen, they strongly correlate over shorter period of time within a few years rather than very long period. Whereas your FRAX position, which usually takes into calculation a 10-year probability of risk fracture, there, that is why, however, it has not found to give a much of a variation, and they say that it should not be included in the FRAX tool for calculating the 10-year probability of fracture. So to summarize, the BTMs have emerged as a tool for the assessment of osteoporosis. The IOF has recommended serum P1P and serum and urinary CTX1, a resorption marker, as markers of choice. They're very useful not for diagnosis, but for monitoring a patients on osteoporosis and predicting the bone loss and fracture risk. And repeated measurements of these markers improve adherence to treatment assessed. However, the biggest challenge is the wide biological variability, but if it is being followed in a standardized same lab with standardized procedures, automated equipments, collecting the sample appropriately using standard protocols, then the repeatability of the assays as well as the precision and accuracy would be so much better on this assays. And definitely these markers are useful because they actually give the status of the bone formation and resorption, and they will be useful. A proper investigation monitoring can help in management of patients of osteoporosis. Thank you so much.
Thank you, Dr. Renuka, for very elaborately going into the whole gamut of investigation and monitoring of the patient. You have very rightly concluded that BTM evaluation will be proportionate to compliance of the drug intake by the patient, and the preferred ones you have detailed about. Thank you very much. Now, friends, I will again share this screen. So we have been talking about secondary osteoporosis, and there are situations where, like diabetes, even obesity, glucocorticoid-induced osteoporosis, but rheumatology patients, they also run supreme when we talk about associated osteoporosis. And Professor Chandrasekhar is going to talk about osteoporosis in rheumatology. Professor Chandrasekhar is the President-elect of Indian Rheumatology Association and is Professor of Chinmoy Rheumatology Clinic at Bengaluru. Professor Chandrasekhar, it is your turn.
Thank you, Professor Jha. I think...
Professor, you need to stop sharing the screen.
Yeah.
Oh, yes. Thank you, Dr. Amarnath. Yes.
I think I will share my screen.
Right.
So I hope I'm visible. My slides are visible?
Yes.
Right. I think in the next 10 minutes, I would like to share on the concept of osteoporosis with reference to rheumatologist. As a rheumatologist, we often see the osteoporosis in two scenarios. Scenario one, where patient walks into us with vague pains and aches, though it is said to be relatively rare, because osteoporosis, we often call it as a silent killer, or more often it is asymptomatic. It can sometimes present with vague pains and aches, especially when you have a vitamin D deficiency and a secondary osteoporosis, wherein we may pick the osteoporosis and try to handle that osteoporosis, or sometimes a silent fracture may have such a severe agonizing pain, and patient may walk into us with severe pain, considering it as one of the rheumatology disease. And when we are screening for any of the rheumatological disease, including osteoporosis, we may identify it as osteoporosis and handle it further as an osteoporosis. But one another conditions where I spend most of my subsequent talk are on where osteoporosis accompanies an autoimmune rheumatic disease. Why we should worry about this osteoporosis? Because one of the critical reason is with the advent of treatment regimens. I think I have seen in the last 2 decades, the way we manage rheumatological disease have changed. We, with the introduction of biologics, with the introduction of available variety ranges of autoimmune modulators, the survival of most of the autoimmune rheumatic disease has significantly improved. Longer you survive with an autoimmune rheumatic disease, more likely you're going to encounter with a lot of comorbidities. Many studies have clearly shown, including the studies related to rheumatoid arthritis, though we have overall improved the survival of the patient suffering from autoimmune rheumatic disease, there is a cutoff. After a certain point, we are unable to increase their lifespan, basically because of the increased burden of comorbidities in these patients. It could be hypertension, it could be diabetes, or it could be so on. Among them, one another important comorbidities which we have to focus is osteoporosis. The osteoporosis is more often ignored as a comorbidity, both by specialists, rheumatologists, as well as the primary care health providers who take care of rheumatological diseases. The basic reason is, as I said, it is one of the silent killer. And other reason is often the vague pains and aches are missed, which could be a part and parcel of osteoporosis. Quite often we have seen the fracture which would have already encountered would have been missed as a part and parcel of the pain related to the existing rheumatological disease, rather than exploring for a possible osteoporosis. That puts us into a first note is when you have a rheumatological diseases patient, one need to keep a tab or keep a watch on osteoporosis, which can come fairly earlier than what we otherwise see in a general populations. So thus, osteoporosis can be encountered, one as a silent thief, where it could be the primary presentation, and the primary presentation could be a fracture or could be vague pains and aches. And the secondary possibility is the osteoporosis could be a possibility which can occur as a component of his existing autoimmune rheumatic disease. There are studies which clearly suggest that osteoporosis could even occur in a patient who has never been exposed to any of the drugs, including steroids. Most often we think that the osteoporosis in a autoimmune rheumatic disease could be because of steroids or could be because of the drugs that we used. It has been shown clearly that even including the disease like rheumatoid arthritis, the osteoporosis may develop in the first 6 months to 1 year. Either it could be localized in and around the joint, or even the systemic osteoporosis could be seen as a component of the disease per se. So in autoimmune rheumatic disease, as I said, most of the autoimmune rheumatic disease are inflammatory and also will have an immobility as one of other component. That could be the reason for the development of osteoporosis. Even the cytokines, which are the key mediators of inflammation, also have a crucial role in increasing the bone turnover and impairing the blastogenesis that can also result in the development of osteoporosis. So osteoporosis in autoimmune rheumatic disease could be primarily because of the disease process itself, and to that add on, the drugs can also cause in the development of the osteoporosis. So when we look into the mechanism of osteoporosis, there could be 2 pathways through which an individual suffering from autoimmune rheumatic disease can develop osteoporosis. Autoimmunity, inflammation, release of lot of cytokines which alters the bone turnover metabolism and result in bone disruption or bone resorption and osteoporosis. Similarly, the drug used, some of the drugs like even steroids, it has been shown in the initial phase. If you use steroids, there could be a reduction in the development or a progression of osteoporosis by inhibition of cytokines, which could otherwise alter the metabolism, inhibiting the inflammation, which could also inhibit the alteration in metabolism and can improvise on paradoxically in the beginning and the initial phase, the progress of osteoporosis, especially when you look for the bone turnovers, what Dr. Renuka was alluding. If you look into those bone turnover, the bone turnover reduction occurs, especially when you introduce steroids. But if you continue to use steroids, there could be an alteration in the metabolism, which is spoken in length by the glucose-induced osteoporosis. And these alteration can cause the bone metabolism disruption and osteoporosis. So osteoporosis in autoimmune rheumatic disease is a double phenomena. One phenomena directly by the disease process, another phenomena by the drugs that we use. So osteoporosis is common in autoimmune rheumatic disease. I just dwell upon few of the common autoimmune rheumatic disease like rheumatoid spondyloarthropathy. What is its incidence, prevalence, and what are the care that one has to take care with reference to that? When you come to rheumatoid arthritis, with increase in life expectancy, we are now also focusing on the quality of life of the affected subjects. Osteoporosis has become one of the most common comorbidity that remains inadequately diagnosed and inadequately identified and treated in this set of patients. So osteoporosis could be asymptomatic and the first presentation could itself be fracture. And sometimes a patient of rheumatoid who is otherwise adequately under good control and who starts developing immobility or starts reduction in the mobility, start complaining of vague pains and aches, one need to consider a possibility of osteoporosis. So only a simple clue in these patients could be reduction in their mobility, and that could be the only clue for which one may have to screen for osteoporosis. So the studies do indicate that both local and systemic osteoporosis can develop in the very beginning of the phase of the disease. Adding to that, we have the immobility, the age, more the elderly, more likely they develop osteoporosis. Post-menopause, if they have developed into menopause, most likely they develop osteoporosis. Prolonged use of steroids and persisting high disease activity are the 5 major set criteria factors which promotes or which increases osteoporosis. So what is the real prevalence of these osteoporosis in rheumatoid arthritis? The report did incidence across the globe. It ranges from 22 to 50%. But when it comes to India, most of the studies where what I could lay my hands on are retrospective, and the prevalence rate has been reported less than 10%, with an exception of one prospective study which was organized in Delhi, which showed a tune of around 15%. Why such a low incidence of osteoporosis in India? Is that we are very highly and effectively managing the patients of rheumatoid, but that's not the truth. The truth is the patients of rheumatoid arthritis in India are younger than compared to the Western counterpart. IORA database, the database which we have reported from Karnataka, and as well as most of you might have seen, the patients whom you see with rheumatoid arthritis are age range between 30 to 55 years, in contrast to a mean age which is reported from Western country, which almost comes to around 50 to 52 years. So the mean age of our rheumatoid patients are lower, and most of them are attain menopause as usual with reference to around 45 or 50. And most of them are physically active. They are forced to be physically active because of the want of continuation of the life. These are the possible reasons why we might be seeing lesser incidence of osteoporosis in Indian rheumatoid arthritis patient. But still, we do see in a woman who develops her rheumatoid post-menopause or walks into menopause over the course of her rheumatoid arthritis and have a persisting disease activity, That's a place one need to screen for a possibility of osteoporosis. Then comes the next commonest, that what we see as spondyloarthropathy, including ankylosing spondylitis. Most of these patients are young. And of course, the biggest difference between rheumatoid arthritis and spondyloarthropathy when it comes to the pathophysiology is, in spondyloarthropathy, it is the new bone formation which is the typical, because you find list spondylitis, you find the new bone formation. Even if you see psoriasis, the ligament gets calcified, you have syndesmophytes, which are nothing but the new bone formation. When it's a new bone formation, do we expect an osteoporosis? That's a question that always be there. And the steroids used in the spondyloarthropathy is relatively less. Basic reason is they are usually not steroid responsive. The only area where we use steroids in patients with ankylosing spondylitis or spondyloarthropathy is whenever they develop iridocyclitis. Otherwise, use of steroids are not common when it comes to spondyloarthropathy. So that being the case, do we really see osteoporosis? So literature certainly indicates the osteoporosis and pathological fracture is one of the commonest comorbidity that you see in spondyloarthropathy. So the incidence has been reported anywhere between 5% to 20%. But one of the major problem in this reporting, or when you are evaluating the patients of spondyloarthropathy, especially ankylosing spondylitis, is because of the development of syndesmophytes, because of the calcification of the ligaments. When you use an AP measurement of DEXA, the patients may have a higher measured bone density rather than what it is actually is. So that's why we need to rely upon the lateral measure of the bone density. What we say is, most of the time, if you see the measurement that we do in the DEXA scan are AP measures, but we have to ask for a lateral measure. When you take for a lateral measure, negating the ligaments which are calcified or the anterior place syndesmophytes, one may figure out or identify a lower T-score or a Z-score. Similarly, if you use high-resolution peripheral quantitative computerized tomography or trabecular bone score, you may reasonably identify the patients with angst and other related spondyloarthropathy to having suffering from osteoporosis. So the reason of underreporting in the literature also could be because the way we measure the osteoporosis, either using DEXA or other methods with reference to osteoporosis. So, and also there are enough studies which shows that using bisphosphonate, including IV pamindronate, which also has been shown to improve to some extent BASDAI score and BASMI score, probably could improve it one is by reducing the disease activity, so also by improving the bone density. So there are the critical role the bisphosphonate has been shown with reference to the role they play in improvising the scores related to the disease activity in spondyloarthropathies. So the low BMD is often observed. It has been reported if you use the best score between 51 to 54%, and but there is decreasing BMD in 13 to 16% of having osteoporosis. But of course, we don't have a specific guidelines when it comes to spondyloarthropathy, though we have a guidelines when to screen, whom to screen, and when to intervene with reference to osteoporosis in rheumatoid arthritis. So we need to keep our eyes open when we are handling ankylosing spondylitis, especially if a patient comes with an acute stabbing pain in one or two segments of the spine, possibility of these patients having an osteoporotic fracture as the presentation of these kind of acute pains episodes. So when it comes to the disease like systemic lupus erythematosus, once again, these are younger patients. The steroid is used in a very high dose in most of these patients. So there is always a possibility of these patients developing osteoporosis much younger age than what we expect in the other set of diseases which I was discussing. And of course, persisting inflammation, if it is not appropriately treated, is one another reason why one can develop osteoporosis. So we need to look for the possibility of osteoporosis, especially steroid-induced osteoporosis, as well as the other drug and disease-induced osteoporosis. And one of the other problem what we see with these patients are avian because of continuous steroids, or even the pathological fracture secondary to the regular use of steroids as well as the disease activities. We do see in other connective tissue disease like inflammatory myositis, vasculitis, there is increased incidence of osteoporosis. We need to keep our watch on the possible development of osteoporosis, and we should keep it as one of the managing strategies when we are treating these patients. So prevention is the best strategy. Control all the risk factors, as I said, which are modifiable risk factors like use of steroids, keeping the disease as active, as less active as possible, promoting the patients to be mobile and active. And of course, what you cannot change is the age, and what you cannot change is the achievement of menopause. Once they achieve menopause, screen for a possible deterioration in the bone density, introduce bisphosphonate and other preventive strategies to avoid the development and progression of the osteoporosis. This can be used by using calcium and vitamin D supplement, bisphosphonate, especially when the disease is quite active. Biologics, especially denosumab, RANKL inhibitors are one of the best suitable drugs in these set of patients because inflammation is the basic reason for the development of osteoporosis, which makes way through RANKL ligands. Using those denosumab would be one of the good strategies in managing the osteoporosis secondary to the disease activity. And of course, at length, steroid-induced osteoporosis management, which is of a different ball game, which will be discussed in details. So in conclusions, osteoporosis could be a accompaniment of other, most of the autoimmune rheumatic disease. It could potentially increase the associated morbidity and mortality. These complications, thus osteoporosis, can further impact the quality of life and overall well-being of the patients. Therefore, it is essential for us to prioritize for a comprehensive evaluations and management of osteoporosis in this set of populations. Thank you very much for your patience.
Thank you, Professor Chandrasekhar, for detailing the existence of osteoporosis in all the rheumatic diseases. And you discussed about the two forms in which it is available. You have to an orthopedic gathering, you have also discussed about the dilemma in spondyloarthropathy when BMD can be detected not in an AP, rather also it must be looked into the lateral view. And any painful situation in the spine, certainly look for whether the patient has a pathological fragility fracture. And this is too incapacitating if one has worst. Thank you very much. Now, Chairman Dr. Amarnath, may I have your permission to speak on glucocorticoid-induced osteoporosis? Dr.
Sir, please go
Amarnath.
ahead. Sir, please go ahead. We are waiting for your talk, sir. Definitely,
Right.
definitely. Most awaited.
Right, friends. Most common form of secondary osteoporosis, and it is the first cause of osteoporosis in younger age group. Now, talking about management, we should first of all understand one basic factor, that we have to classify our patients into age more than 40 and age less than 40. And the moot question is, when should osteoporosis medication be instituted? Well, this will depend directly on, remember, risk stratification, that what is the kind of fracture risk stratification. And how do we come out? Three factors. Glucocorticoid adjusted WHO FRAX tool. Till now, we have known about WHO FRAX tool. Then talk of lowest T score in the whole skeleton and history of fragility fracture. Now, let's know that this is BMD, and as I have earlier said, that in premenopausal age of women and men below 50 years, it is not the T score, it is the Z score, where the value has to be -2 or lower at lowest skeletal site. So this becomes important in lesser age group. This is the FRAX score. Now, risk stratification, how do we get it adjusted as WHO has recommended? So glucocorticoid adjusted WHO FRAX tool. Now, risk stratification in a drug-naive patients aged more than 40 years with osteopenia on BMD and without fragility fracture. Now, what is the formula? In a patient more than 40 years or above, the fracture risk calculation is as follows. Now, if the patient is supposed to be on 7.5 milligram per day or more, the calculated WHO FRAX risk will have to be multiplied by, this is a fixed one, 1.15 glucocorticoid adjusted value for major osteoporotic fractures for 10-year fracture risk. And this same figure becomes 1.2 for hip 10-year fracture risk. So 1.5 for MOP and 1.2 for hip. Now, low fracture risk are patients who have less than 10% major osteoporotic fracture and 1% hip fracture prediction. Now, what are medium fracture risk? It will be 10 to 19%. Mind you, if it is 20%, then it is established osteoporosis. Or for hip, it is 1 to 3. If it is 3%, established osteoporosis or high dose prednisone exposure, which is equivalent to 30 milligram per day, and total dose should be more than 5 gram in last year. Now, what is high fracture risk? This is 20% or more MOP or 3% or more hip fracture prediction. Now, if T-score is lesser than -2.5 at any site in postmenopausal women or men aged more than 50 years and there is a history of previous fragility fracture. Now, glucocorticoid therapy in more than 40 years, what should be the effective medication? Friends, the management of osteoporosis in all age group will have bisphosphonates, denosumab, and teriparatide. Now, there is significant improvement in BMD and reduction of fracture if these drugs are used. Now, how do we go about it? Low risk patient, age more than 40 to 50 years, either starting or currently on glucocorticoid with anticipated duration of therapy of 3 or more months. If there is more than 4% loss of BMD in past year and the T-score is less than 1.5, expected to be on prednisone 5 to 7.5 or more milligram per day for 3 months, then we have to prescribe preferably oral bisphosphonate, alendronate or risodronate. But if the patient is intolerant to oral bisphosphonate, IV zoledronic acid and denosumab is the treatment of choice. In a low risk of patient, monitor with yearly clinical fracture risk assessment with BMD testing every 2 to 3 years. Now, what is the recommendation in medium risk scenario? If the patient is on prednisolone more than 2.5 milligram per day, again, oral bisphosphonate, denosumab, or zoledronic acid intravenous. Now, in high risk scenario, on prednisone more than 2.5 milligram per day, oral bisphosphonate, denosumab will be more effective than oral bisphosphonate, and zoledronic acid IV or teriparatide in lowest T-score can be recommended, less than 2.5, and history of fragility fracture. So, if the patients are into another group of lesser than 40 years, what are the various factors guiding treatment? The risk stratification here depends on 4 factors. Number 1, history of prior fragility fracture, Z-score as I have told you, the dose of prednisone, and bone loss by DEXA scan. How do we know about bone loss? If there is 1 T-score down, that means 12% bone loss has taken place. So difference of 1 T-score says 12% bone loss. Low risk, no matter of worry, no risk factors other than being on prednisone. Medium risk, spine or hip Z-score is -3 or below, or there is 10% decrease in BMD in 1 year, and continuing prednisone is more than 7.5 milligram per day for 6 months, or there is high dose, still higher dose prednisone exposure like 30 milligram per day or more, and the total dose is more than 5 gram in last year in all the patients aged more than 30 years. So high-risk patients, there has to be a prior osteoporotic fragility fracture. Now, how do we treat them? The patients either started on glucocorticoid or currently on glucocorticoid with anticipated duration of therapy more than 3 months. In lower risk patient, oral bisphosphonate if there is more than 10% loss of BMD in 1 year, or expected to receive more than 5 gram in total over the next year. In medium risk patients, again, same bisphosphonate, denosumab, and teriparatide has to be used if pregnancy is anticipated. Now, in high-risk patient, same as in medium risk, teriparatide is the preferred one, and it should be used when there is history of fragility fracture or the Z-score is -3 or lesser side. Now, the therapeutic guidelines in a childbearing potential with previous fragility fracture: treat only if continuing prednisolone, give oral risodronate. This is theoretically the safest oral bisphosphonate, has potential of less fetal toxicity in possible pregnancy. Teriparatide is another alternative, and we must all understand that denosumab is contraindicated in pregnancy. So what are the guidelines for patients on intermittent pulses of IV glucocorticoid? There is no clear-cut directive, but in high-risk patient receiving 4 or more monthly IV pulses of 1 gram methylprednisolone or equivalent, or 4 or more high-dose oral pulses of prednisone 60 milligram per day with taper over 2 to 4 weeks within 12-month period as per the stratification risk laid down. Now, a patient who has been prolonged inhaled steroid, patients on daily inhaled steroid equivalent or higher doses than 200 mg per day for a prolonged period of time, maybe 20 years, can lose bone. One score is 12%, one T-score variation is 12% bone loss. So these patients are also to be periodically monitored. Well, all these patients will have to be followed up, and finally, corticosteroids or glucocorticoids used partly in rheumatic diseases and mainstay of treatment for asthma and COPD can lead to osteoporosis. Effective strategies to prevent bone loss and or to treat osteoporosis include non-biologic and biologic osteoporotic drugs, both anabolic and anti-resorptive, apart from calcium and vitamin D. Thank you very much. Now, friends, moving on to the next topic, if there is loss of muscle mass associated with loss of muscle function and strength, usually accompany osteoporosis. Now, awareness of this association with osteoporosis is a very vital for skeletal muscle mass health, which constitutes 60% of body mass and becomes important in older adult. So now Professor Chinmoy Das from Dispur will speak on osteosarcopenia, which is often neglected. Now I stop sharing. Professor Chinmoy, please. Professor Chinmoy, you can share your
Yes,
screen.
sir, yes. So I think it's visible, sir.
Yes, visible, audible.
Yeah. So thank you. And I again congratulate all the speakers and all the members who have joined us today for this IOA Bone and Joint Week, first day of IOA Bone and Joint Week 23 in this wonderful webinar. And as the last speaker, I think half of my topic is already been done. So all the speakers, they spoke about the osteoporosis part. So I will try to avoid the osteoporosis and stick to sarcopenia as far as possible. And so again, osteoporosis, as already has been described, is characterized by reduced bone mass and increased fracture risk. Whereas sarcopenia, it refers to the loss of muscle mass, strength, and function, according to the European working group of sarcopenia in older patients. So definition of osteoporosis, already it has been covered up. The prevalence 18.4 to 20.7% in India, and worldwide it is around 200 million. And as the aging population is also increasing and the changing lifestyle habits, so this number is going to definitely increase. Prevalence and definition of sarcopenia is low muscle strength, quantity and quality, but as well as low physical performance. Increased with age leading to sarcopenia and its associated consequences. It can be acute and affect a significant percentage of older adults, and prevalence of sarcopenia is from 5 to 50% in population over 65 years of age, and it is estimated that 500 million people worldwide by 2050 will be affected with sarcopenia. But is sarcopenia inevitable? No, it is not inevitable. So impact on health and quality of life with both coexistence of osteoporosis and sarcopenia creates bone and muscle deterioration. It's a cycle because both the diseases, they are synergistically affecting the body, one synergistically affecting the other. The osteoporotic fractures can result in severe pain, disability, and functional limitations, and the combination of reduced bone density and muscle weakness may further increase the risk of falls, which is one of the major causes of fractures in elderly, and functional decline. There is another term called frailty. I will not touch it, just I am mentioning it. It is associated with an increased risk of functional decline and impaired resistance to stresses. The risk factors, already it has been told, there are modifiable and non-modifiable risk factors for osteoporosis, but some shared factors are there with sarcopenia, that is reduction of the hormones, estrogen and testosterone levels during aging. They can affect both the bone density as well as the muscle mass. There are some markers, interleukin 6 and TNF alpha, tumor necrosis factor alpha. They have been implicated with the pathogenesis of both osteoporosis and sarcopenia. Age-related hormonal changes, chronic inflammation, inadequate nutrition, they can contribute to both the conditions, and often they share common risk factors and underlying mechanism. Lifestyle factors such as physical inactivity and poor nutrition, they can negatively impact both bone health as well as muscle mass. Impact of sarcopenia on bone health and vice versa, impact of osteoporosis on sarcopenia. They lead to decreased bone mineral density as well as impaired bone remodeling, what Dr. Renuka was explaining to us. Then there is a newer term called muscle bone crosstalks. That means some muscle derived factor, some myokines, they are found to influence the bone metabolism. And the decline in muscle mass associated with sarcopenia can disrupt the regulatory interaction and contribute to bone loss. Fractures, again, they exacerbate sarcopenia by reducing the physical activity, the immobilization period is increased, and loading to muscle, these lead to muscle disuse and further muscle loss. Pain and limited mobility, they also affect the muscle mass as there is loss of physical activity and exercises due to pain and limited mobility. Combined effects of physical function and mobility, this muscle strength is crucial for maintaining balance and postural control, which are vital for various activities. They have got synergistic effect on physical function and mobility, and both conditions, they combine together and give effects can result in greater functional limitations due to reduced mobility. And compromised bone strength and reduced muscle function synergistically contribute to an increased risk of falls and fracture, which leads to prolonged immobilization and muscle disuse, exacerbating the cycle of functional decline. What are the clinical implications? The interrelationship between osteoporosis and sarcopenia has significant clinical implications, both, and they should be considered in the assessment and management of individuals at risk of these diseases. So screening and diagnostic tools, as already has been described by Dr. Renuka, should evaluate both conditions for a comprehensive assessment of musculoskeletal health. Challenges in managing osteoporosis and sarcopenia, together they include developing integrated interventions that address both conditions simultaneously. So clinical assessment of osteoporosis, already Chaddha has told that history is the main tool what we have, and we should be able to use it. This includes the medical history, the physical examination, the BMD measurement, and the laboratory test. The medical history helps in identifying the risk factors such as past fractures, comorbidities, or lifestyle choices. Physical examination may reveal your height loss, kyphosis, and skeletal abnormalities. PMD measurements using DEXA is the gold standard for assessing bone density. And laboratory examinations, as has been already been described by Dr. Renuka, the calcium, vitamin D, PTH, and other relevant biomarkers, they are the parameters. So for sarcopenia, you need to evaluate by your time up and go. There is a TUG test which asks the patient to sit up from the chair, walk a distance of 3 meters, and then return back and sit in the chair. So these tests, they are objective tools, but they are very helpful in diagnosing sarcopenia. Additional tests like 6-minute walk or this short physical performance battery may be used to evaluate the physical performance of the patient. The bioelectrical impedance analysis or the body composition analysis can be used to estimate the muscle mass, the lean muscle mass, and they can be described. They are described in your weight in kilograms over your height in square meters. There is a questionnaire, SARC-F questionnaire, that looks for your the strength of the muscle, the assistance in walking, the rise from a chair, and C stands for your climbing stairs, and F stands for your fall. So this questionnaire is a very simplified method which can be given to the patients to see whether there is a risk of whether there is a risk and whether there is a established sarcopenia in those patients. Again, DEXA, DIA, CT, or MRI can be used for measuring the muscle, confirming the diagnosis. Treatment guidelines of osteoporosis. The primary aims are to reduce the fracture risk, improve bone health, and manage underlying conditions, lifestyle modification, weight-bearing exercises, balance training exercises, then treatment with your drugs, calcium, vitamin D supplementation, or fortification of the foot, which has been mentioned by Dr. Amarnath, then and other pharmacological agents like your bisphosphonates, SERMs, these denosumab, teriparatide, already just now, Sir has already described it. So treatment guidelines, it should focus on preserving and improving the muscle mass, strength, and physical function. Adequate protein intake and nutritional optimization are crucial for muscle health. Vitamin D supplementation, it's a very important vitamin to maintain the body. Then resistance training is considered the cornerstone of sarcopenia management. And it's a multidisciplinary approach involving healthcare professionals that is very beneficial for the patients. But sometimes you need to have individual care and conclusions for individual care to the patients, and the treatment guidelines may vary according to across the region or organizations. There are tailored interventions, including customized exercise programs, nutritional plans, pharmacological treatments. They can be developed on individual characteristics and needs. And genetic profiling, this is coming up, the biomarker assessment as described by Dr. Renuka, the molecular diagnostics, they are being investigated for identifying individuals at high risk of osteoporosis and sarcopenia. Prevention and management of osteoporosis and sarcopenia, first and foremost, is lifestyle modification, where benefits of weight-bearing exercises, awareness for this, walking, jogging, dancing, and all those things patient can be made aware of. Then sunlight exposure, which is the highest easily available source of vitamin D, is very much needed. And fortified food, the importance of bone health and muscle mass. The patients should be educated, and means they should be made aware of that. Adequate nutrition, then benefits of resistance exercises, then comes the drugs. Lastly, the bisphosphonates, SERMs, denosumab, teriparatide, or the anabolic agents like testosterone and vitamin D. fall prevention. This is one of the major cause, falls in elderly. Falls are not only because of osteoporosis or sarcopenia, it can be due to your visual problem. The environmental modifications for safety should be done, like putting bars, holding bars, then balance and strength training exercises, importance of vision assessment, then medications, because elderly populations, they are on a lot of medications. The medications review should be done, then reducing the morbidity and maintaining independence. It's a multidisciplinary approach. As I have already said, there is role of physician, nurses, therapists, dietitians, involvement of healthcare and research professionals, then it's a collaborative effort for optimal care, addressing potential side effects or complications, and regular monitoring and follow-up is what is needed, because these old people, they are usually neglected. So there are some research advancements like your high resolution peripheral quantitative CT scan and MRI, which offers good improved assessment of bone microarchitecture and muscle quality. These advanced imaging modalities, they provide a more detailed understanding of the structural changes in bone and muscle, and early detection and personalized treatment approaches can be facilitated with the help of these diagnostic tools. Some emerging therapies are there, like your targeted approach, such as the use of specific bone-forming agents or muscle-binding compounds. They are being explored. Regenerative medicine strategies, including the stem cell therapy and tissue engineering, they hold promise for promoting tissue regeneration and functional recovery. Combination therapies and synergistic approaches, integrated interventions that simultaneously target both osteoporosis and sarcopenia, show potential for improved outcome. Exercise programs, already I have said. Then technology-based interventions are there, where there is advanced technology like your virtual reality, the wearable devices, and mobile applications. They can facilitate remote monitoring and delivery of your personalized exercise program. And as I was searching for this virtual reality, I came across mobile app called Oculus P. I think Oculus P. That's a virtual reality. It's very convenient for the aged population to wear, and it helps in their psychosocial environment. Real-time feedback on exercise technique and adherence. That is very important, since most of our patients, they don't adhere to what you have said or what you have prescribed. They can be provided through these technological interventions. Long-term outcome of osteoporosis and sarcopenia, functional outcomes, fracture rates, hospitalization, and healthcare costs should be explored in research to inform evidence-based practice and healthcare decision making. Sarcopenia, as we are in the just ended, or I think we are in the middle of COVID-19. So sarcopenia has become a predictor of poor outcomes in COVID-19 patients due to its link with chronic inflammation, immunological dysfunctions, respiratory muscle failure, and swallowing dysfunctions. So in conclusion, I want to say that osteoporosis and sarcopenia significantly impact the musculoskeletal health and quality of life. A comprehensive approach is crucial for their assessment and management. Preventive measures, as Dr. Chandrashekhara has said, that prevention is better than cure. So preventive measures such as lifestyle modification and fall prevention strategies can reduce the risk of developing these conditions. healthcare providers, they play a vital role in identifying and managing individuals at risk. Advancement in diagnostic tools, therapies, personalized medicine approaches, and technology-based intervention offer promising avenues for the future, and promoting awareness and implementing evidence-based intervention are key to reducing the burden of these conditions. These are my references, which I have used in the chapter also. And lastly, I thank you and seek your blessings and support for IOA 125 at Guwahati. So you can have a lot of places. I couldn't cover all the photographs here. We are having 8 national parks. That's the most attractive destination, I think, for the orthopedic surgeons. So I seek your blessing and support for IOA 125 Guwahati. Thank you, sir.
Right. Thank you. Thank you very much, Professor Chinmoy, for
Yes, sir.
making a masterly presentation and making people aware. And I think simple awareness of the fact that sarcopenia is a condition which will accompany osteoporosis, and hence it is osteosarcopenia. You made a very important observation, not that this is inevitable, it could be preventable. And I think steps have been taken by clinicians because of the consciousness created, and this is being formally taken care of. Now, you did talk about muscle-bone crosstalk, and I think this we have been understanding as a surgeon treating fractures, that whenever there is an associated fracture, you have to look into the muscle health. Now we are talking about this muscle-bone crosstalk, and that becomes very important. So thank you very much. Now we switch over to the discussion part. If there are other persons there, okay. Now, any questions? There was a dilemma expressed by Dr. Amarnath. Yes, that if there is hypercalcemia, is there chances of getting a stone formation more? Yes, Dr. Amarnath, would you like to make a comment yourself first?
See, hypercalcemia due to what? One. And the major thing what happens is hypercalcemia is a relative challenge, but definitely related to the drug induced. So naturally, we need to focus on that. And if there is any primary hypercalcemia due to a comorbid condition, that need to be addressed. In general, people who are going to be on anabolic agents like teriparatide or even abaloparatide now, there will be hypercalcemia, which is a transient in a 24-hour window. So that should not worry some people about causing renal stones. Hypocalcemia definitely focuses on the renal stones rather than hyper in that true sense of term. When once the oxalate stones are formed, eventually they get calcified, but it is not just calcium in the blood or hypercalcemia which is causing that. I would like to just compile that and then give that message. Hope I was clear there, Dr. Jha.
Right. Professor Chandrasekhar, your comments? Hypercalcemia and stone.
Hypercalcemia per se doesn't lead to stone unless the individual has hypercalciuria as well as phosphaturia. Unless those are not matching, usually per se we don't see hypercalcemia resulting in stones. I mean, there is one another thing which is also confused about is atherosclerotic calcification and calcium intake. They are also unrelated. So renal stone formation, calcification in the tissues are not a result or as a consequence of the hypercalcemia per se.
Right. So this myth is broken. Dr. Renuka, you wanted to say something on this topic?
No, sir,
No.
I think it's fine.
Oh,
But
okay.
I think
Yeah.
I was just wondering, never is serum calcium levels done in these cases? Maybe after, if a patient has been constantly on it for long, and suppose if there is increased calcification, patient might have other symptoms like hypercalcinosis cutis or something like that. We do see such kind of conditions sometimes. So probably more because of other disorders metabolic rather than just an increased calcium intake is what I feel. But is it not required that a calcium level should be done?
Normally not. When you are going with the calcium supplementations, we don't recommend a regular calcium test being done unless you have a pre-existing condition. For example, sarcoidosis. If you have a sarcoidosis, if patient has hypercalcemia or patients have other endocrinal disorders where there is a hypercalcemia, it's preferable you avoid loading them with calcium because of the problem, metabolic and other neuronal problem more related to hypercalcemia rather than the stone and tissue calcification.
Of course.
There is a lot of emphasis regarding bone-specific alkaline phosphatase, how really important it is. But in practice, we are not getting these tests done at the local level.
Bone-specific alkaline phosphatase is much better when we're looking in for osteoporosis rather than alkaline phosphatase as such, because there are other isoforms like placental and liver.
Right.
But still it has its limitations. And after a lot of, only thing advantage over there is that sometimes even in patients with renal failure, it sometimes helps when we are doing the monitoring of this.
Dr. Jha, while we are on the question with Dr. Renuka, I would ask one question. Am I okay?
Oh,
Yeah,
yes,
sure, please.
Fantastic. Thank you. Now, you mentioned about the bone turnover markers.
Yeah.
Now, when there is a very high bone turnover, we all know that P1NP is going to be higher. Now, the question comes, when a treating physician or a surgeon or a doctor, like we practicing doctors, do the P1NP first, and there's a very high turnover which is happening, we know that's going to be there. But how do I come and take it forward when I monitor the patient following a teriparatide in a 3 months' time or even maybe half yearly? Where do I stand? Is there going to be much increase than what is already there? Or do we expect the bone turnover markers to come down? But there is an issue there because we are not giving them the what is called as osteoporotic or what shall I say, bisphosphonate therapy.
No,
So
no.
how
When
do
you
I
are giving an
how do
anabolic
you
agent
give?
like teriparatide, at that time it is mainly the bone formation marker like PNP, which value will increase. Initially itself, the patient might have a high level, but then how significant it is, like you usually look for a variation of about 50% variation in serum markers. Then you know that, or when you look at the reference values initially, when you do a testing, and then you see how significant the change is. That's why I said you need to monitor all these BTMs by a, we mention as least significant change. How much change is significant? So either a 30% in urinary markers or 50% in serum markers variation, if it is there, then you know that there is some change which is happening. But resorption markers will not change much with using teriparatide. It will be mainly the formation marker which will increase in the value. Resorption markers will change when you are using bisphosphonate therapy or denosumab.
I agree with you.
Yeah.
Now, the patient has a P1NP of 250 or even 300. Now I initiate, I know it's bone, there's a high turnover. I initiate a teriparatide because he or she has -4 in T-score. So now I expect the bone turnover marker to increase.
After
Now,
3 months, usually you will see a peak value.
I'm sorry?
Usually after starting therapy, usually after 3 months, it starts peaking.
Correct. Now there is already a peaked 300 level. Now,
That
where do
will
I
go beyond 300, doctor.
So there is no frightening.
So instead of 300,
alarming.
you will have it as 450.
Correct. So
Then
now
you know that it
this
is.
is the message. This is the message I wanted to give it to others, because
So the
they should
change
know
which
that-
happens, the significant change which happens,
Yeah.
that is
yeah.
important. If it is from 300, it has moved to 305, then probably a patient is not taking therapy and it's better to check.
Or
The
maybe
patient is
non-responder.
actually
Or
taking
maybe a non-responder.
Sorry?
Or maybe, sorry to interrupt, or maybe a non-responder.
Non-responder, yes. But before, most likely it would be good to look into whether the patient is actually taking therapy.
So
Right.
I would
But it's
definitely-
usually given, sorry?
Yeah. So I think definitely with the guidelines coming in with the IOA, I think these things are going to be very, very clear for all the practicing clinicians to make sure that we follow some sort of set guidelines to make sure that our patients and our nation is much better that way. Great. Thank you. Thank you. Thank you.
A
Yeah.
lot of clarity has been given by Dr. Renuka. Yes,
Yeah.
yes, madam, you were saying something.
I was also saying, but
Dr. Renuka.
currently I notice, as you said, that there are not many orthopedicians who start therapy and actually lose these markers as such. Even for that
100%.
matter, the usage has become much lesser than what I saw 5 years or 8 years back. So that's what I wonder. What is it like? What is the reason for it?
Yes,
One,
yes.
Being a part of the endocrine society, a lot of endocrinologists are also not recommending it. One, you made a very good point with P1CP to P1NP, the variation and the circadian variation also is going to be very, very high. So P1NP has a very less variation. I think that is the one which we need to highlight, and the guidelines definitely going to bring the bone markers to a different level now, definitely.
Right, thank you. We are getting late, so now I would request Professor Chandra. You want to say something, Professor?
Yes, I have raised friend.
I just want to say something, sir, regarding that hypercalcemia thing. In cases of hypercalcium, means, or rather in any other mineral, if it is more in the body, the kidneys will excrete it. That is the basic funda. So any mineral, not only calcium,
Right.
but in these patients, they are already deficient, hypocalcemic. So in these patients, there are very less chances of getting renal stone until and unless he or she is having a renal problem. But there is a condition where there is an autosomal dominant, this hypocalcemia, where this is a hereditary condition, and where the urinary calcium is very high. In those cases, we can have some nephrolithiasis, but that percentage is very small, and that the stones are also, the sizes are very small. So directly taking calcium will not lead to it's a misconception amongst the patient that we are taking calcium, we will have
Stone.
So
Professor Jawahar
Yes,
Jaiswal.
I have the similar impression that a time has come when patient is asking, I have a stone, should I take calcium? Now, is there anything in the literature where patients are having multiple renal stones? What about the calcium? Have the reverse way people have investigated that those who are having multiple time stones, what is happening to their calcium level and the calcium stock? That is one thing, but my point is very simple, that Professor Amarnath has explained about the various calcium salts. Is there a particular salt which is likely to increase this calcium stone, renal stone? And second point, which is very important for me, is to every patient asks the similar questions, but none of the small literature or manual of any tablet or injections of the calcium, they write down that if you have a renal stone, please do not take it. So anywhere in the world, is there any warning written down anywhere?
we cannot generalize the stones as such, because when stones are removed, analysis of the stone has to be done, that it is what kind of a calcium composition of the stone.
So, sir, my point is simple. FDA, when they are allowing the drugs to be used by patients, do they give warning on the label of their medical, strips, that this is not to be used?
Yes.
Now, I actually see the calcium supplement per se, as I said, doesn't produce stones. So now the practical tip is, suppose you
The
have
calcium level
comes
changes
with
on
a
the PTH and
who comes with
PTH.
a history of stones. Say patient says that he has a history of stone, previous stones, past history of stone. Then you need to look back into the analysis whether what is the type of stones, whether it is a calcium stone, phosphate stones. Those patients, you can subject them to look for urinary calcium and urinary phosphorus. And if their urinary calcium and phosphorus are on the higher side, those are the set of patients where you have to avoid supplementing calcium. Since it's an isolated case, it's not a part and parcel of the calcium supplement per se. You need not have that black box warning what you are talking about, because it's not a universal problem or not a problem linked to the calcium supplementation. It is a problem which is linked to an individual case where they have a calciuria or phosphaturia or those oxalate urias. Those are the patients who have an increased susceptibility to develop a stones along with your calcium supplements. So the best way is past history of stones. Ask your urologist colleague or yourself can do those urinary calcium, urinary phosphorus, and urinary oxalate excretion. If they are high, best to avoid them calcium. But you come into some sort of circumstance, patient has osteoporosis, you need to supplement these set of patients on a calcium along with the other supplements. There you can little bit stingy in giving calcium on alternate days, use citrate preparations or other preparations which has a lesser calciuric potentiality, along with supplementing little high vitamin D, which reduces calciurias. And that's the way we can manage those set of patients.
Thank you. Thank you very much. We are already very much delayed. And Professor Sharat Agrawal from Shillong, he is waiting for his part, saying thank you to each one of us. Professor Sharat, please.
Thank you, sir. Good evening, everybody present here. I am Dr. Sharat Agrawal. Just to introduce myself, I am professor and in charge pediatric orthopedics at NIGRIM Shillong. I would like to begin my vote of thanks by expressing our gratitude for Dr. Atul Srivastava, President IOA, Dr. Ram Chaddha, President-elect IOA, Vice President Dr. Anup Agrawal, and Dr. NAVIN THAKKAR, Secretary General in absentia, and President IORA Dr. Shantanu Lahkar for constantly supporting the program for the spread of awareness on orthopedic issues, surrounding the presidential theme of strong nation with strong bones. And of course, our only one and none, Dr. SS Jha, sir, for spearheading this campaign by constantly holding the webinars on rheumatology as part of IOA subcommittee on rheumatology. I would like to thank uh, Dr. Murali Poduval from Mumbai, Dr. SS Amarnath, Dr. P Renuka, and Dr. S Chandrashekhara from Bengaluru, Dr. Chinmoy Das from Tezpur, and for giving the insights on various aspects of osteoporosis. Of course, the very basics are the most important things which I always believe in as a teacher here also. I would also like to thank Team OrthoTV, especially Dr. Ashok Shyam, Dr. Neeraj Bijlani, and Dr. Shamsul Huda to widely disseminate these activities in orthopedic domain. In the end, as part of the rheumatology subcommittee, my sincere thanks goes to the delegates and attendees of today's webinar, without whom these webinars are of little consequences. Without taking much of time, extend my apologies if I have missed out any name amongst the council who was actively involved in this
Also
today's
thank
webinar.
Miss Poonam. Thank
Yeah,
Miss
yeah. Thank you,
Ortho
Miss
TV.
Poonam, yeah, from Ortho TV to have given us this platform and doing the needful, the recordings and all, and putting it on the OrthoTV platform for its dissemination in the near future.
And
Thank you
Aarti
to all of
Dewan.
you once again. Pardon, Dr. Amarnath,
And
you want to say
Aarti
something?
Dewan has been in the background.
Oh, yes, Dr. Aarti Dewan. And of course, I don't know Dr. Dilip Majumder and Dr. Ranjit Kumar from Patna was supposed to join. They were not there.
Aarti, you are back.
So I would like to thank them also. So
I saw the
as,
message that you have left. Okay.
so as panelist, I thank them
Dr.
also.
Jawahar Jethwa is also there.
And
Okay.
our
Ah,
very
yes.
senior sir, Dr. Jawahar Jethwa. And thank you to all once again. And long live IOA and Jai Hind.
I am personally grateful to Professor Chandrashekhara, Dr. Renuka, and all our colleagues also for having participated and taken interest. Thank you very much.
Thank you, sir. Thank you.
Very
Thank you.
welcome.
Thank
Thank
you.
you.
Thank you.
We can
Very
say
much.
good night.